It's become sort of almost culturally expected among patients to be able to get rid of all my pain, 100% of my pain, and by pain I mean all my suffering, with a pill. And so that expectation is too common, and providers always want to help that. So, providers used to be told, you're not doing a good job unless you prescribe whatever dose it takes, whatever your patient wants.
My message to my colleagues would be to be measured with the opiates. There's still a role for opiates in the treatment of mostly acute, subacute pain after surgery, after an injury, etc. When it comes to using opiates for chronic pain, we now have a lot of data showing that it's really not that effective for a lot of different chronic pain issues.
What I would say is, doctors, please learn what impact you're having on the real world. You can be fooled by patients for sure, but when a student comes in, for instance, with a sports injury, or a dentist, a patient of yours needs to have teeth extracted, please don't use that pen and write a narcotic prescription, painkiller prescription unnecessarily. There are other treatment modes, and they can be very effective.
And so instead of saying, the old explanation of if all you have is a hammer, everything looks like a nail, that's what we were using. And now we realize we don't just have a hammer, we have all kinds of stuff to work with. And so reaching out to different providers and asking them, what has worked for your patients? This particular kind of patient, for example, chronic pelvic pain, can I get them into the pelvic floor physical therapist? And all of these different options we didn't know anything about. They were possibilities that have grown because of the work that needed to be done. But even just tapping into that as emergency providers and realizing all the opportunities we have for different therapies has made the biggest difference.
We need more drug development of effective analgesia, particularly for extremely complex patients and patients with complex pain conditions that are very hard to treat. And while some of them exist, most of them are not really feasible to be implemented at a primary care level. So it does mean if you're going to try to treat patients with some of these few drugs that we have that are non-opiate but also highly effective, you have to have access to specialty care.
It's really hard to re-educate a medical community. This over-prescribing that we do has been forced upon us, and it's not even a matter of physician education, it's re-education, and we keep changing our minds in what we're telling physicians. So it makes it very difficult, and that's just for the medical community. That's just a small piece of the epidemic. The whole epidemic is, our whole culture of, pill-happy society. So we have a lot of work ahead of us.